let me check. Candidate 5, yeah, I think you have.
Yes.
You are with us?
Yes.
Okay. Now, over to you.
This is axial CT of the brain, non-contrast. You can see that there are linear hyperdense areas in the left high frontal region and in the left basifrontal region. I would like to look at the bone windows to assess for any fracture, as this could be related to trauma.
So there is history of trauma. Anything else vis-a-vis trauma? Do you see anything else?
I do not see any midline shift, no other there is an area of hyperdensity in the right high parietal region. So this could represent an area of contricup injury. There is also an area of extraaxial collection in the right occipital region.
Occipital?
Not the tentorial, right tentorial region.
Sorry, where?
The right tentorium.
Tentorium. Okay, anything else? In the parent traumatic subarachnoid hemorrhage. So classical exam case where there are multiple findings. Now, we are not going to cover subarachnoid hemorrhage. We have covered it many times in the past. Just a recap quickly that this thing, whenever you see a case of trauma, please remember subarachnoid hemorrhage might be associated with it, right? So even if it is extradural, subdural, contusion, whatever, subarachnoid hemorrhage, look for subarachnoid hemorrhage, get some brownie points for that. The examiner might give you half a point, or sometimes this will be the only finding, and then you will get more marks for it. The satisfaction of search is what we are talking about. Please remember that traumatic subarachnoid hemorrhage is the most common cause of subarachnoid hemorrhage. Now, satisfaction of search, isolated supratentorial sulcal blood and interpedunclar cistern maybe, or blood in the interpedunclar cistern may be the only manifestation of subarachnoid hemorrhage. Look here, there was a subdural here, and within the interpedunclar cistern, there is a bit of subarachnoid. So this is the exam type of subarachnoid. Multiple examples where if you see here, so many things are happening, but there is some subarachnoid in the interpedunclar cistern. Again, here also. And then look at this, in the last slice, there is subarachnoid hemorrhage high up in the vertex. Is there any subarachnoid hemorrhage here? Candidate 5?
Right sylvian fissure.
Excellent. So there is subarachnoid hemorrhage here in the right sylvian fissure. Any subarachnoid hemorrhage here? Candidate 5?
In the left, left parietal, temporoparietal. Yeah, left.
Yeah. So if you see here now, the learning point here is that if you go to, though it becomes an easy case because you can see the same thing on multiple slices. But beware of a case in which you see it only on the final slice. Key point is that you see this, there is something happening, and on the right side, there is normal CSF. Again here, and again here. Look at this. It is all filled up. It is filled up. There is CSF here. So this subarachnoid hemorrhage might be 1 or 2 days old. It's not very high dense. We've covered all of these, so I'm just going to rush through it. This is a case in which there is subarachnoid hemorrhage, which is 6 days old. On a CT scan, you don't see it now, but on a flare sequence, you can see it. And the key point is that when on a flare sequence, subarachnoid hemorrhage will be high signal and you are expecting normal low signal within the sulcus. There is something high signal here. Please remember that this particular case, we know that this is subarachnoid hemorrhage. Otherwise, we have covered it in the past. Usually in the examination, they will show you this kind of finding on a flare sequence, and you will tackle it like this, that there is high signal within the sulcus here. This might be subarachnoid hemorrhage. However, it might be any leptomeningeal process, as in leptomeningeal carcinomatosis or infection, etc. So you have to give contrast. Subarachnoid hemorrhage, of course, will not enhance, and other processes will enhance. So this is sulcal flare hyperintensities. This is from your book, and all of these things can happen: bacterial meningitis, aseptic meningitis, carcinomatosis, etc. And with that is subarachnoid hemorrhage as one of the differential. And this is a classical exam scenario where you will pick up something on the flare sequence, you give contrast, and it will enhance. And this particular case was esophageal carcinoma. I've shown you this in the past, so this is a revision slide. We are just coming to the end, and then I will show you maybe a few DICOM cases, classical viva cases. So this is, okay, over to you. What is happening? Candidate 5.
This is an axial CT non-contrast of the brain, which is showing area of hyperdensity in the right parietal region, extending to the area of the I think there's a metallic foreign body.
Excellent, well done.
A metallic density foreign body from the right occipital region laterally. There are a few local foci of air seen in the right frontal and temporal regions.
So what's your conclusion?
There is a hemorrhage in the right, along the tract of the right occipital region, as well as pneumocephalus could be related to the procedure.
Procedure?
Sure. Metallic density artifact, what is, I can't understand.
How do you explain that? This is an A&E case.
This is a burhole drainage for the.
Okay, I'll take over. This is a gunshot wound. And the idea was to show you a gunshot wound just so that you don't forget it. It's easy, but you have to remember. And now there are multiple metallic foci. You can see the track of one of them. You can see a lot of bone marrow, sorry, a lot of edema. You can see pneumocephalus. And on a scout, it is better seen. But just wanted to show you a gunshot. Now, pneumocephalus. Pneumocephalus, key point is pneumocephalus can be in any compartment. Remember this concept. It can be in the epidural compartment, it can be subdural compartment, subarachnoid, and parenchymal. When it is parenchymal, just remember the word which we use in lungs, nematocele. So it is known as a nematocele. It can be in the ventricle, it can be in the vessels. You remember I showed you a jugular vein blood, air bubble. It can be in the ventricle. Nematocele is important, but I'll come back to this point. There is a sign which we call Mount Fiji sign, which is at times seen in tension pneumocephalus. I'll show you. When you see, this is an extremely important concept, and you will use it in your exam very often. When you see something low density in the CSF, it will be blacker to human eye as compared to the CSF. It can either be air or it can be fat. Remember the case of ruptured dermoid. Fat will be low density. In your exam, you will ask the examiner that I want to check the Hounsfield unit. Air will be, minus 700, 800, minus 1000. And fat will be anywhere between 50, minus 50 to minus 100. So, and please remember in your clinical practice, many a times you will see air in the cavernous sinus. And usually it is because of IV excess. Usually it is of no clinical significance. You can see this air quite. So this is what we call Mount Fiji sign, where there is Pneumocephalus. And so this is the mounts, both of the frontal lobes, they give this pointed appearance, and this is known as Mount Fiji sign. And this is known as tension pneumocephalus, just like a tension pneumothorax. And it has to be drained just like a tension, what we call pneumothorax. This is nematocele within the parenchyma. This is air in the ventricle. Another example, you remember I showed you a case of air bubble in the jugular bulb, which was because of dural sinus laceration. Here, there is a fracture which has ruptured the carotid artery, and you can see that there is a bubble within the carotid canal, within this portion of the carotid artery. In this case, there are multiple bubbles which are in the subarachnoid space, in the ventricles, again in the subarachnoid space, the quadrigeminal cistern. Another example of a fracture, orbital fracture. This is preseptal space, but there is pneumocephalus here also. Now, this example, in which we can see multiple air bubbles or nematocele, whatever you want to call it, within the parenchyma. This is because of air embolism. Now, air embolism usually is because of air in the veins. At times, it is not very critical. But sometimes in this case, this particular case, what had happened is that air went, because there was a patent foramen ovale, it went into the arteries. And ultimately, it caused air embolism. When there will be air embolism, there might be stigmata of, small infarctions, etc., also with it. The point what I am showing you with these examples, that air can be in any compartment. Remember this. And once again, the case which I showed you earlier today, in which air bubble was there in the jugular vein because of this fracture and because of the laceration in the transverse sinus. Candidate 5. Any findings in subarachnoid space in this case?
There is a focus of air in the right temporal region.
Yeah, and in this one?
Interhemispheric region, in second image.
So is it air or is it something else? How will you check?
I would like to check the Hounsfield unit.
Yeah, that's fine. So this was a ruptured dermoid, and this was, of course, a pneumocephalus. So even here, it looks black to the human eyes, blacker than this. So must ask for Hounsfield in your examination. And so look at this case, tension pneumocephalus, lot of brainstem, base of skull fractures, and look at this. And so this kind of a case will require surgery or drainage. Do you see this? How, look at the mass effect. Yes, please.
This is the exensity of the brain showing non-contrast, showing large air-filled cavity in the left temporal region. There is There is also an extra-axial collection in the left temporal region. I do not see any bony calvareal defect. There is midline shift to the right side, mild. There is a narrowing of the ipsilateral lateral ventricles.
So what is this? What is this?
The post-traumatic sequelae. Pneumocephalus.
How can you confirm that this is a pneumocephalus? When we checked the density, it was water density. So let me tell you, this is a trick case and a potential exam case. You see, what is happening is, first of all, there is something here. And this something is CSF density. If you look carefully, look at this bone. There is scalloping and a bit of expansion. So this thing is sitting there for a while. This is an arachnoid cyst. This patient had an arachnoid cyst. With that, the patient had trauma. So there was an extradural hematoma. And with that, there were some diffuse axonal injuries. So interesting case, but I just wanted to check the reflexes. You know, don't jump to conclusions when you see something black, what it is. It might be fat, it might be CSF, it might be air. So ask for CSF. This is a very unusual case, but I just showed you to check this particular aspect. When so fractures, etc. Usually I show a lot of cases of base of skull fracture when we will cover head and neck. But having said that, please remember the temporal bone, which is usually seen on a axial slice. So on this axial slice, what are your findings? Over to you.
This is axial high resolution CT of the temporal bone. I see that there is a transverse fracture of the right temporal bone with some fluid within the mastoid head cells. There is no ossicular discontinuity.
What is happening here? This is the key finding which I wanted you to pick up.
The malleus, head of the malleus is dislodged.
Yes. So you see what will happen, what happens is, this is the epitympanum, where this is the incus, body of incus, the head of the malleus. This is what we call ice cream cone. This is the ice cream and this is the cone. It should be sitting here. So this is dislocation, incudo-malleolar dislocation, and you can pick it up on a regular CT brain. Remember that. Though I am showing you a temporal bone study, because these days when you do on a spiral CT, it's all 0.625 images. Of course, you have to do reformats then. Another thing is that this is longitudinal fracture. It's not transverse fracture. The concept in temporal bone is, consider the temporal bone as the human body. You know, from here to here is the longitudinal axis. If this fracture is going like this is a longitudinal fracture. And if it goes like this, then it's a transverse fracture. So these days, nobody is interested in, literature will tell you that longitudinal fracture more likely to involve X type of injuries and Y type of injuries in transverse. But if you ask me, it is all irrelevant. And main thing for your exam, for your 2B exam, is you have to pick up this thing, incudo-malleolar. And of course, this is another example where what is happening. If you see this is head of Malleus, it should have been sitting on this. It is not sitting on this. So this is another incubomalleolar. Now, just a recap, because we have covered this in the past, revision, because of, this is what we call a growing fracture or a leptomeningeal cyst, whatever you want to call it. And the concept is that when there is a fracture, arachnoid, there is a rent in the arachnoid, which then there is pulsation of the CSF, and then the dura, it extends outside, and it keeps growing. And this is the concept of a leptomeningeal cyst. And we have covered this in the past. Skull wall lucency without sclerotic edge. This is leptomeningeal cyst, also known as growing fracture. So, final point is regarding two terms. One is cephalohematoma, and second one is subgaleal hematoma. This one is seen in infants, and this one is seen in infants as well as in other age groups. What is the definition here? This is a subperiosteal hematoma in between the outer table of calvarium and periosteum. It is actually the opposite of an epidural hematoma. It is an epidural hematoma but sitting outside the skull. And this is seen in infants. Subgaleal hematoma, on the other hand, so this cephalohematoma does not cross sutures. And subgaleal hematoma, it forms under galeal epineurosis of the occipitofrontalis muscle. It is not limited by sutures and it can be very large. Point to remember that cephalohematoma can be seen in 1% of newborns, usually caused because of forceps delivery, etc. On the other hand, subgaleal hematoma is usually seen in all age groups. So this, I think this vocabulary should be in, correction, this word should be in your vocabulary. And please remember that sometime in infants, a subgaleal hematoma can be clinically significant. It can become so large that it can cause life-threatening effect. So this is a cephalohematoma and this is a subgaleal hematoma. So there is a fracture here, and this is cephalohematoma. There was an epidural also. This, on the other hand, in infant is a subgaleal hematoma. Final, okay, your last case, please. This is your last case, and then I'll go to candidate 6. Over to you.
It's an axial CT of the brain, non-contrast.
Just 1 second. Just one second. Now, the point is that this is an acute over chronic subdural hematoma on the left side. I know that it is very obvious. I am giving you marks for your description and your findings and what is happening. Over to you.
There is a large extraaxial collection in the left fronto-temporoparietal region, which is isodense to the surrounding white matter, gray matter. There is also internal hyperdensity seen within this, suggestive of an acute or chronic subdural hematoma. This suggestive of the swirl pattern. This collection is causing mass effect in the form of compression of the adjacent brain parenchyma with midline shift of so much, and there is also narrowing of the ipsilateral lateral ventricles. There is a narrowing of the ambient system, obliteration of the ambient system, and basal systems. So I will inform these findings to my reference clinician.
So what is the conclusion?
This is an acute on chronic subdural hematoma with mass effect.
What do you mean mass effect? Can you be more elaborative? In conclusion, I just want you to conclude it.
There is midline shift. There is and midline shift and obliteration of the basal systems.
What does that mean? You see, this is your description. I want you to conclude. Tell me, how will you conclude this case?
Chronic suffering.
Tell me which kind of herniations are there.
There is uncal herniation. There is
okay. You please mute yourself, and I'll take over the case and take it from there. Now, this is a case of when you see this kind of a case in the examination, the examiner is actually checking your concepts about herniation. Your description is one thing, but your conclusion has to be, is there subfalcine herniation, is there transtentorial herniation, etc. Now, if you go into details, there are various types of herniations in the brain. Subfalcine herniation, unilateral descending transtentorial herniation, bilateral descending transtentorial herniation, also known as central herniation, ascending transtentorial herniation, tonsillar herniation, transdural transcranial herniation. In your exam, these two are most important, and this one, by the way, any case which has got huge edema, as in, you know, earlier today we saw a few cases of diffuse brain swelling. Ultimately, this is what happens. But what I'm going to teach you today is subfalcine herniation and unilateral descending transtentorial herniation. Look at the definition. In subfalcine herniation, cingulate gyrus is displaced under the falx, and then it does something which I'll teach you. And in unilateral descending transtentorial herniation, what happens is that the medial most portion of the temporal lobe, which is the uncus, it goes into the tentorial hiatus, and there are some findings which we will learn. Now, if you see here, this is subfalcine herniation, this is falx, this is the cingulate gyrus, and there is a mass sitting here. In this case, it can be a hematoma, it can be a tumor, whatever, and it is causing this to go to the other side. Here is the uncus, and it is going into the tentorial hiatus. So these are the two things which we have to learn. Key anatomy features include at the midbrain level. At the midbrain, this is the midbrain. There is ambient cistern. This is uncus, and this is suprasellar cistern. So when this thing goes here, what it will do, there will be effacement of the ambient cistern. It all depends how severe it is. Then it will compress the midbrain. Then it might displace the midbrain to the contralateral side. So there can be various kinds of magnitudes of transtentorial herniation. This is the suprasellar cistern, and the suprasellar cistern will be effaced. Then there will be something which will happen to the CP angle cistern. This is the CP cistern, cerebropontine cistern. Ipsilateral cerebropontine cistern will become more prominent, and the contralateral will be less prominent. I'll show you cases. In subfalcine herniation, please remember, foramen of Monro can be effaced or blocked. So that will produce some effects which we will learn shortly. Another point is that in transtentorial herniation, the PCA, which passes through the ambient cistern, can be compressed. So there can be PCA territory infarction. As far as subfalcine herniation is concerned, the ACA, which is here, can be compressed and there can be ACA infarctions. So coming back to this case, what is happening? There is a mass here which is acute over chronic subdural hematoma. It is causing midline shift to the contralateral side. Because of that, there will be compression of the foramen of Monro. And because of that, what will happen? The contralateral lateral ventricle will be dilated. Look at this temporal horn, it is dilated. So when you describe subfalcine herniation, you have to use this kind of terminology. There is a, so I'm just going through that terminology. There is an acute over chronic subdural hematoma on left side in the frontal and parietal region, which is causing significant mass effect. Midline shift to the contralateral side. There is effacement of the lateral ventricle on the ipsilateral side, while there is dilatation of the lateral ventricle, particularly the temporal horn on the contralateral side. This is the description of the subfalcine herniation. As far as transtentorial herniation, concentrate here and tell the examiner that I can see evidence of transtentorial herniation with displacement of the uncus into the incisura. The midbrain is compressed and distorted. The suprasellar cistern, now ask yourself, where is the suprasellar cistern? It's not visualized. The suprasellar cistern is effaced and there is dilatation of the ipsilateral CP angle cistern as compared to the right side. So these are the findings of transtentorial herniation. Now, just to give you examples of other kinds of herniation, this is tonsillar herniation. This is what we call transcranial herniation. This is a post-surgical defect here, but we are just interested in the two which I have mentioned. And please remember, these are the clinical scenarios which you have to mention to the examiner. It can cause infarctions. Subfalcine herniation, ACA territory. Descending transtentorial herniation, PCA. These ones are not all that important. Tonsillar herniation can cause pica infarction, not all that important for your exam. But secondary signs, as in hydrocephalus, you have to tell that. Then Kernohan's notch, I'll explain to you what does that mean. First of all, subfalcine herniation, which we have already covered. Cingulate gyrus displaced under the falx. So this is the mechanism, and because of which there can be secondary obstruction of foramen of Monro, and the ACA can be infarcted. As far as descending transtentorial herniation, it can be early, it can be moderate, it can be severe. So here, these complications are important. Kernohan's notch. What happens is, there was a pathologist by this name, Kernohan, who described this in a post-mortem study, where there is a sort of indentation. What happens is that the midbrain goes and it is compressed with the dura on the contralateral side. Please remember, the corticospinal tracts are going there, and the patient will get false localizing signs, as if there will be hemiplegia, which will be ipsilateral to the mass. So this is Kernohan's notch, which can be there. Then there can be hemorrhages in the pons and the medulla. We call them Durant hemorrhages. So these are the complications of transtentorial herniation. Look at this example. And this is the uncus which is sitting here. So this is the last case of the day as far as the PowerPoint is concerned. Candidate 6, are you with us?
Yes, I'm with you.
Okay, so can you describe it, and then I'll show you a few DICOM cases.
Yes. So these are axial images of CT brain unenhanced in a 24-year-old unconscious patient with history of trauma 2 months back. I can see that there is a concavo-convex extra-axial left-sided collection overlying the left cerebral hemisphere. It has a fluid level with hypodensity anteriorly and hyperdensity posteriorly. In the context of trauma, this most likely represents an acute or chronic subdural hematoma. I can also see that there is significant mass effect on the left cerebral hemisphere with midline shift to the right. There is the ipsilateral / left lateral ventricle is compressed. There is prominence of the temporal horn on the right side, which denotes hydrocephalus. There is element of subfalcine herniation. Coming to the level of the midbrain, I can see that there is a mass effect on the left hemi-midbrain, denoting left-sided uncal herniation, with obliteration of the ambient cistern on the right, meaning that there is mass effect on the right side of the midbrain as well. So in conclusion, this is an acute emergency because of the mass effect and the intracranial herniation. If I may add, I can also see some hyperdensities in the inferior frontal lobes. I would make sure that these are not artifacts from the bone, but I would be concerned regarding any new hemorrhages in the inferior frontal lobes. In short, this is a surgical emergency. And I would pick up the phone and immediately inform the neurosurgeon that this patient needs urgent intervention for the management.
Okay, well done. But did you mention suprasellar system?
No, I didn't.
So please remember that in transtentorial herniation, particularly, you remember that we can divide it into early or, magnitude-wise significant. This is the suprasellar cistern is going to be effaced. Basically, brain is going down and being compressed with the base of skull. So you have to mention that. Where is the suprasellar cistern? You don't see it. Agree?
Yes, exactly.
So you have to mention it as a finding. Number one. Number two, look at the CP angle cistern. So
yes.
You see this is
dilated.
Prominent, yeah, as compared to the other side. And this finding is usually seen, at times it is not seen. But in this particular case, it is seen.
Right.
Second thing is, last thing, did you mention this?
No, I didn't. This is infarct in the right PCA territory because of the uncal herniation.
Yes. And so this infarct can happen on either side. One can argue that maybe something is happening. No, but this is definite, right?
Yes.
So these are the complications. And in exam cases, you might find some hemorrhage in the brainstem, in the pons or the medulla. And that is, you remember that urate hemorrhage. So please, description as well as complications. And the complications can be development of hydrocephalus, any infarctions, Carnohan's notch, or urate hemorrhages and things like that. Okay.
Right. Yes.
Okay. Now I have got a few DICOM cases which I am going to show you. Now I am using, usually when we do viva, we use Mac, but I did not have time to download the cases there. So I'm going to show you on this Radiant. My experience with Radiant is that the mouse at times doesn't work very well. Let's see if it does work. And otherwise, I'll scroll it for you. So just 1 second.
Yes.
So I've got many cases and I am going to select a few good ones for you. So, and these are classical exam cases, right? So, let's see if your mouse is working. Can you scroll?
Yes, let me try.
Yeah. So this is trauma. Over to you.
Okay. Okay. So I've been provided with axial CT brain images unenhanced in a patient with CT trauma. I'm going to scroll through the images once before I start describing my findings. Okay, so this is a patient with trauma. So in this patient, I'm looking for any intraventricular, intraparenchymal, subarachnoid, or extradural hemorrhages. When I was scrolling in the posterior fossa along the tentorium on the left side, can you see my mouse, sir?
Yeah, yeah.
So when I'm comparing the tentorial leaflets on both the sides, I feel that the left side is a bit hyperdense.
Don't worry about this.
Okay. So I also feel that the area of the around the brainstem, the cisterns around the brainstem are relatively effaced. I'm having a second look. I'm looking for any hemorrhagic contusions. I'm trying to look. There seems to be a dense left-sided MCA sign.
Don't worry.
Yeah, this is a trauma patient.
Yeah.
Okay. I think the hyperdensity I feel in the orbit is also projectional, because when I scroll, the orbits look fine. I'm going back. Sorry, I'm going on the opposite side. So I'm scrolling up again. The ventricles do not look dilated. I do not see any midline shift. I do see some hyperdensities on the scalp surface, which could be foreign particles secondary to trauma. The sinuses do seem to have some fluid, which in the context of trauma will make me concerned regarding basal skull fracture. So I will look at these images in bone windows as well, especially to rule out skull base fractures. Okay, so I have been provided with the bone windows. So I'm going first to the base and then I'll scroll up. So scrolling up, I'm paying special attention to the mastoid and the squamous part of the temporal bone. There is some opacification of the right-sided mastoid air cells, but right now I'm actively looking if I can find a fracture at the base of the skull. I'm also trying to look at the middle ear ossicles. They look fine to me. I am going up now. The sinuses are filled with fluid, which is worrisome for me in a trauma patient. Okay. So I believe there is this fracture, there is dehiscence of the bone at the posterior aspect of the sphenoid sinus. So that is why there is fluid in the sinuses. There also seems to be fracture involving the lateral wall of the orbit, as well as the apex of the left orbit. So there are multiple fractures involving the orbit as well. In fact, the right side as well. So there is, so basically there are multiple fractures involving the boundaries of both the orbits as well as the posterior aspect of the left sphenoid sinus. I would be very concerned about this patient. I would pick up the phone and involve the neurosurgeon as well as the faciomacillary surgeon for active management of this patient.
Right. Okay, let me take over. Now, protocol-wise, you have to be more, should I use the word more smooth in the protocol? Because there were times when initially, you know, for example, you must have a protocol. I will go through the parenchyma.
Yes.
And you have to start, first of all, you cannot see everything on your first, try. So go till the vertex, try to see till the vertex, then come back and things like that. So at times you were going from one part to the other. So that was my observation.
Right.
Second thing is, please remember, never stop just on axial slice. It is in your day-to-day practice, in trauma cases, what we do, we pick up something and then we go for reformats. Some of the findings will never be confirmed unless you do reformats. Another point regarding base of skull is that classical teaching is that never make a diagnosis just on an axial slice. It is absolutely legitimate, and this is why it is legitimate, because this is what we do in our day-to-day practice. Base of skull, the slices are going longitudinally through it, so you have to ask for coronal as well as sagittal if you want. So in this particular case, your conclusion was that you were worried about some fractures, and you should not have said that I will, pick up the phone and things like that. First of all, tell the examiner that I want to see the coronal or sagittal for the confirmation of your findings.
Right.
But the key thing is your protocol. Now, if you see here, this is the TMJ. You see this?
Yes, I do.
This is the TMJ. This is the condyle of the mandible. And this
Right.
is how it looks like. And where is it?
It's dislocated on the left.
Yes. Right?
Yes.
So the point is, it is sitting here, right? It is sitting
Yes.
here. And this was the finding actually. There was a fracture of the mandibular condyle. So the point is that more robust protocol as far as the base of skull is concerned. That is, let me see, where is the coronal? This is the coronal. Why is it showing? I wanted to show you a coronal. Yeah, this is the coronal. So, you see this?
Yes.
So, that is what it was. Now, as far as the sphenoid sinus is concerned, there is a bit of what we call chronic sphenoid sinusitis, where there is thickening of the wall. So that's an incident loma. But the key thing is this thing, right?
Right.
This was a case of mandibular condyle fracture. So then we go to another case, which is, so this is another trauma case. Here you are. Over to you, please.
Okay. So these are axial images of CT brain unenhanced in a patient with trauma. So I'm scrolling, and initially I'm concentrating on the parenchyma. Look for any hemorrhagic contusions or any hypodensity in either cerebral hemisphere. Now I'm concentrating on the extra-axial CSF spaces, on the subarachnoid, looking for the subdural or the extradural spaces. I can see a pneumocephalus, a small air focus, along the left side of the falx anteriorly. So this is one of the positive findings which I have picked
Can
up.
it be anything else other than pneumocephalus?
Yes, I would like to know the hypodensity, the Hounsfield's unit of this density, because it can be fat as well.
So this is only 50.
So this is fat. Okay. I am a bit concerned regarding the hyperdensity in the midline, in the region of the falx. But it's
Can you point it to me?
sorry, this one, sir.
Okay.
So while I trace it posteriorly in the region of the superior sagittal sinus, the density is different. But anteriorly, it looks hyperdense. And it's perfectly midline. So I am a bit debating whether this is incidental falx calcification or this is acute hemorrhage in the region of falx in the midline.
Right.
As I scroll down, I see that this hyperdensity seems to have a propensity towards the left, towards the right, sorry. So this is, so I believe this is right-sided parafalcine subdural hemorrhage. And there is some hyperdensity in the adjacent sulci as well on the right cerebral hemisphere. I'm pointing with my arrow. So there is element of subarachnoid hemorrhage as well. I'm scrolling further. I'm having a look at the ventricles to see if there is any blood in the ventricles. I don't see any. The sylvian fissures also look okay.
Okay, can I stop you there? Absolutely fine. This was the finding. Well done. So this was a classical, what we call observation film. The only thing is that there is a bit of course, I did not give you time for that because of time factor. The main finding you have picked up, it was an observation film trauma, subtle finding, but you did well to pick it up. This was parafalcine subdural with traumatic subarachnoid. Well done. So next case, please. Let me just 1 second, please. Let me. Over to you.
Okay.
Trauma case.
Axial images of CT brain unenhanced in a patient with history of trauma. I'm scrolling craniocaudally, and as I'm scrolling and looking at the parenchyma, I feel that there are, I can see that there are multiple hyperdense area in the posterior parietal region and also in the right frontal region. I'm scrolling further down. I'm looking, I have found another one in the, a very subtle one in the left frontal lobe. This is the area which I'm pointing. I'm also keeping an eye on the midline falx, on the rest of the brain parenchyma. There seems to be a few subtle hyperdensities, again, in the right parietal region. I have come to the level of the ventricles. I'm looking if there are any blood in the ventricles. I do not see any. There is no midline shift, no blood in the sylvian fissures. I'm having a look at the tentorium. The tentorium appeared to be a bit hypertense bilaterally, not on one side. I'll reconfirm it on the coronal images. The foramen magnum, the cisterns appear to be preserved. The suprasellar cistern can also be seen. So what I have found till now is there are few subtle hyperdense areas scattered in both the cerebral hemispheres. And in a patient with trauma, I'll be concerned about the possibility of diffuse axonal injury. I look at it at other reformatted sequences, coronal and sagittal. And
okay, hold on, please. Just hold on. So, whatever you want to see, what do you want to see, coronal or sagittal?
I'll look first at the coronal because I'm not happy with the tentorium cerebelli.
Okay.
I believe this tentorium cerebelli, yes, this tentorium cerebelli is a bit hyperdense and left more than right. This area is hyperdense, so I'll be concerned about tentorial subdural hemorrhage. I'm having a quick go at my area of suspicion of hemorrhagic foci in the posterior high parietal region. So this is one. If I can show it with my arrow, I'm not happy with this focus in a trauma patient. I'll keep my threshold very low in such patients and would raise the suspicion of diffuse axonal injury. This seems to be outside the brain parenchyma. These are calcifications. But one of the I have two concerns here: the tentorial subdural hemorrhage and a subtle hypertense foci, which I saw in the left cerebral hemisphere. I will of course see the sagittal images as well and ask the clinician regarding the Glasgow coma scale in this case. And if the Glasgow coma scale is low, then an MRI would help further in evaluation of diffuse axonal injury.
Glasgow coma is 15 actually.
Oh.
Okay, I'll give you a. So this is the sagittal, and can you confirm your findings?
Okay. So in the sagittal, I again see that there is no herniation. I'm just concerned about this tentorium. I still believe that the tentorium is a bit more hyperdense. As the patient's Glasgow coma scale is perfectly fine, so I believe the hemorrhagic focus which I felt is maybe projectional, but I still believe that there is subdural, bilateral subdural tentorial cerebelli hemorrhage.
That's fine. So it was only as you picked up, the only finding is subtle subdural. You've picked up very well. Well done. So that was fine. Everything else was actually nothing. So overall, well done. Now, let me show you. What is the time? Oh, we have gone beyond time. In any case, let me show you one or two more cases.
Sure.
So these are classical exam cases. So over to you.
Okay, so these are axial images of CT brain in a patient with history of trauma. I can see there is a hyperdensity, linear hyperdensity in the midline with areas of hypodensity as well. This is, I'm going down further and the same findings are persistent as I scroll down up to the level of anterior cranial fossa I can also see subgaleal hematoma and the periorbital hematoma. I'm having a second look, and now I'm concentrating on the cisterns, on the gray-white matter differentiation, on the sylvian fissure, on the ventricles. So I believe the main finding here is this hyperdensity in the midline. I believe this is right-sided parafalcine subdural hematoma. However, I do have my concern regarding whether this is a sort of thrombosed superior sagittal sinus as well. So to ascertain it further, I will have a look in the coronal and the sagittal images. And if still I have my doubts, I will proceed with a IV contrast to confirm my finding.
Yeah.
Okay, sorry.
Sorry, I think some of the other I have. So this is the corona. Over to you.
Okay, okay.
If you double click it, it will become larger. You want it larger?
Yes, sorry,
So
I did
Leave the
something.
mouse for me. Leave the mouse.
Yeah, sure.
Okay, over to you.
Okay, so these are the coronal images of the same patient. So again, I see this midline, and it has a propensity towards the right side. So I'm more inclined towards a right parafalcine subdural hematoma with hypodensity, which can be explained by some arachnoid tear, which has gotten mixed with the high density blood. So I would convey these findings to the neurology and ask about the neurological status of the patient.
Hint, satisfaction of search.
Yeah, so there is thickening of the tentorium cerebelli on the right side.
Doesn't change anything, isn't it? Because this is the same subdural which is going into
Exactly, exactly. Okay, so now I'm having a second look, and I'm looking whether there is effacement of sulcine gyri on the affected site, but they seem to be intact. I can see I think there is a hyperdensity on the left side as well. There is another focus of subdural hematoma involving the left cerebral hemisphere. And so basically this is bilateral subdural hematoma. The one on the right seems to be parafalcine, but one on the left is involving the left parietal region. I'm just having a look if I'm missing any intraparenchymal hemorrhagic contusion.
Look at the soft tissues.
There is the subgaleal hematoma and hematoma around the frontal region and the eye in the periorbital region. So so this seems to be like an open wound with hematoma on involving the left side. I'm just looking at the orbit itself. So yes, this whole left-sided subgaleal hematoma is there involving the frontal and the left orbital region.
The patient has got diplopia and vision is affected, left eye.
So with his vision of the left eye is affected. So now with this history, I'm concentrating on the left optic nerve and the pathway. So I'm going to so this left optic nerve, this is where I'm pointing.
Don't worry about the optic nerve. Anything else?
I'm trying to look if there is any effacement of the suprasellar cistern or in the region of cavernous sinus. there is some mass effect which would explain the diplopia. I would also, in a trauma patient, look in the bone window. Oh, sir, I found it. The inferior, sorry, this is inferior orbital floor fracture on the left side with entrapment of the muscle, and hence his symptoms of diplopia.
Okay, so we stop here. So you see, now ultimately you did reach it, but what is the lesson? Satisfaction of search, right? Now,
Yes.
if you see here, in trauma cases, always what is satisfaction of search? First of all, you picked up the findings. Even here, there is something happening here, right?
Right.
Did you see this? Something
Yes.
is happening here. Now, this something, what is it? So let's have a debate what it is. If we go to the coronal, which is this one, and go, let me change the windows. What is happening? Just 1 second.
Sure, sir.
Now, this thing here, you see this thing here?
Yes, absolutely.
And how do you explain this? You see, it is sitting, it is not subdural space, it is not subarachnoid space, it is hanging in the subarachnoid space. And you see the configuration, and actually it goes and then maybe communicates here. You know what is happening in this particular case? With this subdural, as you tackled in the beginning, there was sinus thrombosis, and this is a cortical vein which is high density.
Right. Right.
So on a CTV, that was confirmed, and as I downloaded these last night, and the CTV is not here for me to show you. Having said that, if you see here now, you see where is the trauma. The trauma is just superior to the orbit, right? And
Yes.
you see this thickening,
Yes.
pre-septal thickening. And look at this globe, you know, a lot of edema around it and things like that. So your mind should have gone into orbit.
Yes.
And if you look carefully, if you go to the bone window here, and this is the optic nerve, we are going inferiorly. Of course, nobody is expecting you to pick it up, but retrospectively speaking, something is extending into the maxillary sinus. You see this thing?
Yes, yes, it does.
Something is extending into the maxillary sinus. And then there is air fluid level. This something, immediately your mind should go, if there is something as in a blowout fracture, and actually there was a blowout fracture, so which you picked up ultimately, right? This thing
Yes,
here.
yes.
So another case of satisfaction of search. Are you still interested in another case?
Sure, sir.
Okay, let me show you a case of multiple findings. So till now I have shown you subtle cases, right? Subtle, you've done very well. But now I am going to show you a sort of a very busy scan. So busy scans also come in the examination, and the findings will be very easy to pick up, but there might be some discussions, and the key point is that you have to pick up everything. Over to you.
Yes. So these are axial images of CT brain unenhanced in a trauma patient. I'm going to describe the findings as I'm scrolling. I can see that there are a lot of hyperdensities in both cerebral hemispheres in the sulci, denoting subarachnoid hemorrhage. As I'm scrolling, on the left side, I can see a lenticular It's an extra axial high density collection, which appears biconvex lenticular shaped, most likely denoting an epidural hemorrhage. I can also see adjacent subgaleal hematoma on the left side, adjacent to this epidural hematoma, and there seems to be a focus of air as well in the subgaleal hematoma. I'm going back to my from where I started. Now, I also feel that the midline is hyperdense. I would confirm them in other images as well. I do see that there is a midline shift to the left. Further evidence of subarachnoid hemorrhage as I scroll down. I can also see a hyperdensity in the left cerebral hemisphere. I'm trying to ascertain its exact location, and I believe this is involving the splenium of the corpus callosum. Furthermore, I can see multiple hyperdensities, for example, in the right frontal region along the cortex. And also I see one here in the left parietal lobe, which are in the context of trauma patient, denotes hemorrhagic contusions. I can also see a large mixed density area, actually a predominantly hyperdense area involving the left temporal, the right temporal lobe, denoting hemorrhage, and it is surrounded by significant edema. Now I'm going to concentrate on the herniations. I have already described the midline shift to the left. I'm looking, and there is subfalcine herniation towards the left. There is effacement of the right lateral ventricle, and the left lateral ventricle is asymmetrically dilated. There is high density in the right lateral ventricle, but this seems to be, I will check the density on the console, but this seems to be calcification rather than hemorrhage, but I will double check on the workstation. I'm coming to the area of midbrain. I'm trying to look at the herniations. I can see the quadrigeminal cistern is fine. However, there is mass effect on the right side of the midbrain, and also a contralateral push to the left side, but still the cisterns around it are still intact. As I'm going down, I'm concerned about the foramen magnum. I do not see any tonsillar herniation, at least in this slices. I'm having a look at the cerebellum as well to see if there is any pica infarct or any other infarct. So I haven't seen any. On the retrospect, I just scrolled through and I saw a hemorrhagic focus in the occipital horn of the left lateral ventricle as well. In my routine practice, I would also look at the bone window settings to look for the fractures.
I'll give you the bone window.
Okay, so in the first slice which has come in the view is that there is two linear fracture lines along the left side of the calvarium, which has minimally displaced inside. So this is concerning for a depressed fracture. I'm trying to ascertain if there are other fractures as well. There is a pacification of the mastoid air cells, so I'll have a quick look at the base of the skull. The patient is intubated, so the patient is critical. I have looked at the left mandibular condyle, it's in place. The right is also in place, so no mandibular fracture. I haven't seen in my scroll any skull fractures as well, any base of skull fractures as well. So the only fracture I've seen at the moment is a depressed skull fracture, in fact, comminuted, involving the left hemicalvarium. In my routine practice, I'll also look in the sagittal and the coronal windows to make sure that I do not miss any other fractures.
So what is your conclusion?
The conclusion is that this patient of trauma has a lot of findings, which include a depressed skull fracture, which is very highly concerning. There is subarachnoid hemorrhage, there is hemorrhagic contusions, diffuse axonal injury, and a very large left temporal intraparenchymal hematoma. So this patient and midline shift as well, with subfalcine herniation to the left. So this patient needs an emergent and epidural hematoma on the left. So this patient needs an emergent intervention by the neurosurgeon, and the patient would need a multidisciplinary management in this case.
Okay, that's fine. I want to just show you the last case. It is a satisfaction of search case, but I will guide you because of the time factor, and I will tell you what to look for. Last case of the day. So in this case, this is trauma case, and
Yes,
you are just place yourself in the examination. You are going through it, and in your soft tissue window, nothing else. And you then tell the examiner that in my routine practice, I see, what do you see? Bone window.
I see the bone windows in all the
bone
reef.
window. So, so the examiner gives you the bone window. Now over to you.
Okay. So these are bone windows of CT brain in a patient with trauma. So in these bone windows, I'm trying to see any fracture. I'll make sure on the thin slices if this partial volumic effect or this.
Nothing.
Okay. So I'm scrolling down. I'm looking at both sides of the calvarium of the skull to see any discontinuity or any lucent line, to see fractures. There are certain lucencies, but I think these are nutrient foramina of the arteries. These, I'm not concerned about these as fractures. There is fracture of the left zygomatic arch.
Again, artifactual.
Okay. So now I'm going down towards the base of the skull. I'm looking first on the left side. There seems to be a fracture involving the left part of the occipital bone. I'm pointing it with my arrow.
It is the suture, don't worry.
Okay, so I'm continuing down the bone windows to look for any fractures. I have come to the level of the cervical spine, and I feel that there is asymmetry in the distance of the right and left between the C1 and the odontoid peg. So in a trauma, and I can also see that there is fracture involving the left occipital condyle. So with a trauma patient, this asymmetry and this of the space and left occipital condyle is concerning for a trauma related injury. I'm just scrolling back to see if this is one fracture which I have found involving the occipital condyle and the C1 with the loss of the asymmetry of the space. I'm just scrolling back.
How can you confirm that?
Sorry?
How can you confirm that?
I can have a look on the coronal images as well, which will show.
Let me give you coronal.
Okay, so now I'm having a look at the coronal and I'm going to the region of interest. And yes, this is the fracture of the left occipital condyle, and I can also see that this is the asymmetry. The left side, the left distance between the C1 and the odontoid peg is more as compared to the right. So this is left occipital condyle fracture with possible ligamentous injury, which has led to the asymmetry of centering of the odontoid peg towards the right. I would actually ask for a CT cervical spine as well, because I want to make sure that there is no odontoid peg fracture, and I'll also be concerned regarding the rest of the cervical spine in this patient.
Yeah, so that's fine. Well done. Actually, this is the cervical spine, and does it confirm your findings?
On the coronal, I still see this is the fracture line which I see in the left occipital condyle.
That's fine. So we stop here. Well done. So now the cases which I showed you today, you see the take-home point in the exam is that in the trauma world, satisfaction of search is very important, and you know it has to be very elaborative type of trauma. Base of skull, I've shown you this. I have the condyle, the what we call the orbital floor of orbit, subtle findings of subdural. All of these are important. But if a case is a gross case, then there will be discussions and viva questions and things like that. So you've done well overall, and particularly the last case you picked up very well. Any questions from your end?
No, sir. Thank you.
Okay then. So I think it was good that we went maybe 30 minutes extra, but I just wanted to show you, particularly the people who are sitting the exam, a few classical 2B cases from the trauma world. So that is about it. The chat is open. And what I will do is next session, I think even if Anjali is fit enough, because of the exam, I think what we will do is we will cover spine. Spine is extremely important for the exam. And I divide my spine into MSK spine and CNS spine. The session is CNS spine, but maybe I'll show you a few MSK spine cases also next time. And maybe I'll sort of design it. Today I had no time to design it. I did it in last minute to show you more DICOM type of cases. So next time it will be spine imaging, CNS spine, and it will be particularly, we will again, the viva candidates will be the candidates who are sitting the exam. So that is about it. Okay, so the chat will remain open for the next few minutes, and see you next week.